of our webinar. My name is Christina Bazans. I'm the CEO of CHATS, Community and Home Assistance to Seniors, and I'm also the co-chair of the Ontario Health Central CSS Advisory Table. So delighted to have so many of you from our sector join today, and I'm really looking forward to this next session with Sumi Chang from Toronto Metropolitan University in Street Haven. We talked this morning with Matt Anderson and Susan Durick, and then for those of you who are able to listen to Dan Carbon as well, about the changes and transformation in the health system, what's happening, some of the implications for the community support sector. And Dan also talked about some of the challenges within the health system and where we could consider becoming more active in doing advocacy to demonstrate the value of our sector and the importance of what we contribute to improved health outcomes for the clients that we serve. Today, we're going to hear from Sumi about how we can become active and effective in integrating health and social care together, what it means and what the essential dimensions for successful integration are. So I'm really pleased today to be able to welcome Sumi Chang, who comes to us from her role as a sessional instructor for the Faculty of Arts and Ted Rogers School of Management at Toronto Metropolitan University. Sumi has a very particular insight as well into the community support sector because she's executive director for Street Haven, which is a women's multi-service health and social care agency providing shelter, supportive housing, training supports, and addictions treatment services to homeless women living in deep poverty. Sumi has over 25 years of leadership experience in the health and social services sectors and governments at the local, provincial, and national levels in Canada. She's worked on critical health and social policy and care issues, including working across the care continuum, food insecurity, housing, public health, and poverty reduction. With knowledge and expertise gained from her work experience and her doctoral research on integrated health and social care for vulnerable populations, Sumi is dedicated to improving conditions for society's most vulnerable through leadership, advocacy, research, and volunteerism. Sumi possesses a PhD from Toronto Metropolitan University in Policy Studies with additional training in public health and community health, and is a certified health executive member with the Canadian College of Health Leaders. Sumi, we're so looking forward to hearing from you. I'll turn it over to you now.
Thank you so much, Christina. It's such a pleasure to be joining all of you at this virtual conference, and a real pleasure to have had Christina reach out to me with regards to speaking about some of my interests around integrating health and social care. For today's session, I'll be talking about integrated health and social care and really trying to attempt to demystify it and to give you an understanding of some of the basic concepts involved in this topic, as well as some frameworks you can use as you embark on your integrated health and social care journeys. I'll also spend a very small amount of time trying to highlight some critical and unique roles that the community support sector can play in this space. And this will be based off of my own research in this area. However, before I begin to do that, just because Christina spent quite a bit of time talking about me, I'd really be interested in getting to learn more about all of you in this audience. And I've actually asked if Christina and her team, Michelle, if they could prepare a poll. And I just have one question for you. And if you could launch that poll, Michelle, for the audience, and just to really ask what your background currently is around integrated health and social care. Sorry, I don't see the poll, so I'm not sure if it's been launched or not.
Yes, launching it now, Sumi.
Okay. Great. If the audience would be interested in taking a couple of seconds just to complete this poll, that would be great. Essentially, it's just asking what your background is, and some of the answers are, I'm involved in one OHT, I'm involved in more than one OHT, I'm involved in integrated care, but not with an OHT. I will be involved in an OHT or some other kind of integrated care, or I'm currently not involved in any OHT or other integrated care. So we're currently seeing a bit of a spread between being involved in one or more OATs and some who are not involved in any at all. And there's a small handful who are currently involved in some other kind of integrated initiative. There's about 117 online right now. Just waiting for, we only have 14 responses. If you'd like to continue to answer that, that would be great. I'll just give it a couple more seconds. I don't want to take up too much of your time here. Looks like a bit of a spread right now between those who are involved in one OAT or more than one OAT, and then those who are currently not involved in any OAT or any integrated care, and then a small number of you who are involved in other integrated care initiatives or will be at the near future. So thank you for that. I'm just going to end the poll. Oh, sorry, I should have shared the results. There you go. There you can see your results. So about an even spread, a third, and then a few who are not involved in, who are going to be involved in the future. All right. So I'm just going to move on to the next piece. And again, sorry, but I thought it would be nice if I engage you in a bit of an exercise. I think before I jump into talking about integrated health and social care, I thought it might be nice if I gave you a definition of what is meant by integrated health and social care. But before I do that, I'm curious just to kind of understand how you view integrated health and social care. And so I wanted to ask if you could go to this site called menti.com. Hopefully you're familiar with it. Essentially, if you go to the site, you have the ability to type in this code 5425. And when you do so, it will ask you to type in one word that you think, that you believe kind of encapsulates what you understand integrated health and social care to be. I'm just going to activate this now. So in case somebody did try and do it and hadn't been successful, I'm just reactivating that again. Sorry, so it looks like the code's changed a little bit. So the code is 48896209. So if you can go to menti.com, www.menti.com, and use the code 48896209, this should, oh, we're beginning to see it. There you go. We're slowly getting some respondents. So we have one respondent writing holistic. Any others? Perhaps the 14 who responded? Impactful, collaboration, client-centered, essential, comprehensive, client responsive, accessible, connected, working together, teamwork, efficient, effective, connected, seamless, future of healthcare, non-siloed, fulsome. So that looks good. Great. Thank you so much for the 34 who responded. Oh, looks like we're getting a few more. All right. So this is really great. And we're really beginning to kind of see where your views and your thoughts are on when it comes to what is meant by integrated health and social care. So that's really exciting. And I think really speaks to kind of where our collective minds are right now in Ontario when it comes to what we mean by integrated health and social care. So we're seeing a few more, 40 are responding, better outcomes, seamless comes up a few times, alignment, protected, funded, collaboration. So buzzword. So that's someone who I think is an interesting comment, community focused. So here we go. That's your word bubble for this group. So that's pretty awesome. Thank you so much. And I'll be sure to share that with Christina, and she can kind of share that with all of you again. So I'll stop share. I'll get out of that right now. And I'm going to come back to the PowerPoint. All right, so thank you for that. So I wanted to go into that exercise because I wanted to kind of prefix this whole conversation around integrated health and social care by saying that integrated health and social care really is an evolving field. there's really no standard definition of what is meant by integrated health and social care. It kind of arose in the 1990s, and it's really been kind of evolving and growing as a phenomenon globally, really with a lot of the activity happening at this point in time, although I guess it could be debated, especially with the work in Ontario, happening in the kind of European continent and UK areas. However, despite the evolving and growing body of knowledge, there's still no one accepted or known definition. And there are lots of definitions that exist. In Canada in particular, even though we were perhaps one of the new kids on the block or first kids on the block when integrated health and social care first came out in the 90s, we've really still been in a bit of a stage of emergence or a state of infancy when it comes to what we're doing in integrated health and social care. And as a result of that, in Canada, there's really no kind of standard definition of how we understand integrated health and social care to mean for us. There's different words that are used to mean the same thing, and there's same words are used to mean different things. So, if you feel that there's no cookie cutter kind of definition, that's because there is no cookie cutter definition. What I wanted to do instead is really just offer you all a definition that's based off of the World Health Organizations. But if you were to Google this, there would be a lot of definitions you would find. And this is one that I've actually adapted for my own research. And it is when healthcare organizations from across the care continuum are working together with social services organizations so that services are complementary and coordinated in a seamless and unified system with care continuity for the patient or client in order to achieve desired health outcomes within a holistic perspective. So with that definition, I'm just going to jump into some of these concepts that you may have heard in your own journeys in integrated health and social care, or will continue to hear. And they can really kind of be categorized under degrees of integration, levels of integration, and domains of integration. With regards to the levels of integration, I just wanted to speak very briefly on that. And that generally means at the micro level, when you're engaging in integrated care, you're really working at integration at the program or care level or client level. At meso level integration, you're really working at integration between different organizations. And at the macro level, you're really working at the systems level. So Ontario is a great example of where we've been kind of on this plus decades long journey of integration and different forms and variations of it. And so that would be an example of macro level integration. With regards to degree of integration, I'm just going to move to the next slide. It really talks about the intensification of integration that happens between organizations. Linkage integration speaks to when organizations are trying to find workarounds to overcome some of those organizational structural barriers that exist between their different organizations, which make integrated delivery difficult. Coordinated integration, which is the next degree of integration, speaks to when organizations come together and build purpose-built structures or processes to try and address those organizational constraints in order to engage in better communication and information sharing. And the last level or degree of integration is really full integration. And this is when different organizations come together and combine their resources, structures, and funding for really long-term and unified services provision, often resulting in whole new structures or entities. In addition to degrees and levels of integration, there are also domains of integration. And this really just means that you can integrate different aspects of the work that you all do. And this was mentioned a little bit earlier today in the introduction. Integration isn't just one thing, it's actually aspects of different things. And so you can engage in functional integration, and this speaks to back office integration. So things that we consider administration, human resources, finance, procurement, all that administrative activity could be considered full integration. Service or clinical integration is exactly what it says, just engaging at the service or clinical level. Same with provider level integration, when providers come together and kind of cross boundaries in order to try and connect and better engage in integrated care. Organizational integration is when relationships are formed between organizations to try and find better partnerships. Normative integration references shared mission, work values, and organizational professional culture that happens between different organizations. And systemic integration speaks to the alignment of policies and incentives at the organizational level between different organizations. I just wanted to show this slide deck really to try and, again, work towards helping to demystify that idea of what integrated care is. These are all examples of what I like to call components or mechanisms of integration. They are not themselves integrated care. They're simply mechanisms that help you move towards what you want to do with integrated care. So single points of entry or common referral forms or common assessment tools, case manager, care coordination, patient navigation, care planning, EMRs, all of these things are simply one aspect or one component of what an integrated care initiative could look like. And so to just be mindful of that, and this is not an exhaustive list. Organizations, depending on their unique circumstances and clients, may conceive of and innovate new mechanisms of integrated care that are not listed or commonly seen. And so whatever your organizations may do as you continue in your journey, you can also consider as being a mechanism of integrated care, even if they don't kind of reflect some of the items on this list. This is a little piece of work that I did around trying to define what is meant by successful integrated care. And I had actually combed the literature and looked for really successful initiatives that are known globally. And I was able to distill all of that information into 18 core characteristics that seem to have been correspond with many of these successful initiatives. The first is that there's a strong element of patient-centeredness in all of these successful initiatives that had a strong focus on the patient and the patient voice and wanting to design systems that were client-centered really were considered some of the most successful. In addition to that, the goals of those initiatives were very common and concrete and shared by all of the partners who were involved in those initiatives. These integrated initiatives were also able to be monitored, and results could be reported on. Quality was a huge feature of the goals of these integrated initiatives. And there was a sense of collective responsibility amongst all the partners who were involved in those successful initiatives, as well as a strong level of information sharing that was happening among all of the partners, whether healthcare or social care. When it came to decision-making and problem solving, these initiatives tended to devolve a lot of that decision-making right to the front line, so that the frontline staff and professions were really able to move the needle on care. And there was a strong shared culture that existed among all of these partners who were involved in that integrated care work. Leadership was very collaborative in these initiatives. And lastly, when it came to staff and professional interaction, that was happening at all levels of the organization. And we were really seeing professionals cross their professional boundaries in order to engage in enhanced integrated health and social care. The last kind of standard principle that I wanted to share with all of you is just these Lutz's laws of integration. Some of you may or may not have heard them, but back in the 90s, as this phenomenon was evolving, Lutz came out with these 5 laws of integrated health and social care based on their experiences in the US and the United Kingdom, especially around providing care for older adults. And Lutz essentially said, look, you can't integrate all services for all people. Essentially, don't boil that ocean. It's too big and it's not possible, and that's not what integration does. In addition to this, Lutz wanted to say, look, integration is going to cost you before it pays. Therefore, you should really try and dedicate money and resources to it. I would also add to this, really from a policy perspective too, is that, and from a planning administrative perspective, is that a lot of initiatives have identified cost savings as a key driver for wanting to engage in integration. An integration that is anchored on that desire to save funds is going to be destined for a little bit of disappointment, because oftentimes, as literature shows, that has yet to be fully proven. Oftentimes what happens in integrated care, because it is very good at finding unmet needs, it often diverts funds from one part of the healthcare system into other parts of the healthcare and social care systems, therefore oftentimes resulting in kind of like a null effect, or even resulting in more costs. This doesn't mean that the integration has necessarily failed. It just means that integration was doing its job in terms of trying to perhaps enhance patient outcomes and care for those clients that were a focus of integrated care. Integration can result in fragmentation and disruption for others or some. And that is just to note that if certain parts of the healthcare system engage in integrated care, it may result in some fragmentation and disruption for others who are not part of that effort. And so that's something to be mindful of. When it comes to integration, it may not apply to all services because of the different contextual features. And I think when we talk about community support services and the proper, what we call the proper healthcare system, or what is, formally falling under the Canada Health Act, when we even look at universal care access services versus needs-based services, even the funding approaches are different. And therefore, there will be some challenges to overcome when it comes to integrating care. The last law of integration, which I think is something that we should kind of take with us as we move into our own OAT journey, is that whoever is leading integration calls the shots. And this is something I think all of us, and especially I think the community support services sector, should really be mindful of as you move into this journey towards integration in the province, is just to, if you want to be involved in integration, is to be active in that space. And lastly, when Litz came back in 2005 to revisit his laws, he also identified one other kind of notation that he wanted to say, and that was all integration is local. And this ties us back to the first law, which is you can't integrate all services for all people. And really, the focus perhaps is to focus on integrating care within your communities and your client base. And those interests and concerns about scaling and spreading can be more of a policy conversation that other decision makers can worry about. And really, for those organizations involved, the focus should really be about context and what's happening in your communities. So I'm going to enter into a part that may seem a little academic. I do apologize, but I'll try and kind of go through this in a very high level way and not get too mired in too much detail. But I thought it might be helpful for many of you who are involved in an OAT or more than one OAT, or involved in integrated care in some other way, or who will in the future, is to give you some frameworks that you might want to consider using as you move in your journey. The first is a conceptual model developed by Valentine et al., and it is called the Rainbow Model. It's very well known by researchers, by practitioners, primarily in Europe and also in the US, and some in Canada as well. And essentially what Valentine et al. Did was tie the different domains of integration with the different levels of integration, and hence why you see this kind of rainbow. And essentially Valentine et al., or the researchers, said that when you begin at the micro level, you will see clinical and professional integration. And as you move up the levels of integration, you will see organizational and systemic integration. What he did want to point out, or what they did want to point out, that irrespective of the level of integration, or it's important to note that functional integration and normative integration is very important at all levels. And so that's something that they wanted to point out when it came to connectivity. Another model that also has been referenced in the past, and also by another researcher, is from the Netherlands, is Mirella Minkman. And she identified or developed this quality management model. And essentially, she identified 89 elements that she identified as being core and integral to integrating and innovating when it came to collaborative work. In addition to that, what was very interesting in her model was that she proposed a temporal or time element, and that she said there are really 4 phases of integration, kind of from the pilot phase all the way through to scaling and spreading. In a later conversation I had with her a couple of years ago, she did admit that this model had not yet been tested outside of the Netherlands. So she did acknowledge that context is very important. And she did say that she wanted to revisit this model because 89 elements was considered too much. So this last model is where we'll spend the rest of the presentation. And I just wanted to kind of state that when it came to integrated care, I had developed an interorganizational conceptual model that was really intended to guide integration work. And my model is based off of some research I did here in Canada with a strong Canadian context-based lens. Essentially, if you look at the model, there's kind of 2 inner rings, and those inner rings reflect elements that are important for organizations to engage in interorganizational integration. And then there's this exterior ring, which are considered external factors that are beyond the control of any one particular organization. And these external factors influence or exert an influence over integration work. So this is just a quick synopsis of what's involved in integrated, some of the case studies that I had looked at to develop my model. The first is in Alberta. It's called the Geriatric Assessment Program Collaboratory. And I just wanted to let you know that's an informal name that I actually made up for them. There is no formal name they have. Essentially, this is a linkage-based collaboration of primary care, of Alberta Health Services and community-based social support and support services agencies in Camrose, which is about an hour north of Edmonton in Alberta. So it's an urban rural area. And essentially all of these partners came together to better support geriatric patients who are actually falling through the cracks in their community, who are not being well serviced by primary care. And they were often ending up in the hospital for avoidable reasons and really not getting the best care possible. So these partners came together to enhance care coordination, care referrals, care navigation, and really anchor it around this geriatric assessment program that I've kind of identified in these area. And they've been very successful. It's been running for over 10 years. The next initiative is actually an initiative that is based out of this North Toronto area. And it's actually the lead agency is the Bernard Batel Center. This, I believe they're actually here at today's conference as well. So, and they may even be at this session. So a shout out to the Bernard Batel Center, Julia and Gail. This is a day program called the Healthy at Home program, and it's been in place for over 10 years. These partners, it's a large group of partners, and they've come together to really try and service a highly marginalized and underserviced and disenfranchised client group, older adult client group living in the community. And they can be bucketed under 3 buckets. There's healthcare partners such as hospitals and community health centers and the former LHIN. There's housing partners such as community housing, social community housing. And then there's a social and immigration agency such as JIAS, the Jewish Russian Community Center. And all of these agencies have come together to try and support these older adults who are living in the community, to provide them with kind of day programming that's focused on not only health, but also social care aspects, and have really developed strong relationships with their clients, all with this lens on trying to provide culturally appropriate care with an emphasis on Jewish Russian-speaking older adults. The last is an award-winning day program in Middleton Day program. It's actually a very rural part of Nova Scotia and the Annapolis Valley, and essentially is comprised of 4 key partners: the Nova Scotia Health Authority, the VON, the Home Care Agency, the Nova Scotia Community College, and then a transportation company, a not-for-profit transportation company called TCTS. These 4 partners have come together and created a therapeutically inspired day program. So it's not simply a day program, it's actually a program that's interconnected with the health authority services such as OT and other home care services. There's care planning involved, there's goal planning that's identified that touches on both health and social care aspects of the clients who attend. This serves older adults who are living in these rural areas who might otherwise have been dropping through the cracks. And it actually acts as a bit of a respite program. They do accept clients, for instance, who have dementia and other cognitive decline conditions. And it really is also part of this care and a caregiver support relief program. This program has become so successful that actually the province has recently spread and scaled this across the entire province. And there are other examples of this program now currently in place across Nova Scotia. My apologies for that. With regards to the integration factors, I'm just going to talk about 2 key factors. One is the communications and shared vision and goals. And these key factors are, sorry, I'm just going to go back up. So communications was viewed as being one of the most important integration factors between different organizations for obvious reasons. It's important for information sharing, for services coordination, but also for partners to come together and engage in collaborative problem solving. The second most important integration factor was shared vision and goals, because it really helps to guide partnership and find and create that common connection amongst a very broad, diverse group of partners. And this common set of goals helps to create that sense of willingness to engage in partnership. Some of the other integration factors include dedicated resources, so allowing these partners to focus on integration without having to do it off the side of their desk, having leadership that's very collaborative so that all the voices are heard and having an opportunity to engage in decision-making, engaging in team-based approaches, which allows for different professionals to come together and engage in shared care work, and creating a culture of not only mutual respect, but also interdependence. That is extremely important because it prevents organizations from wanting to compete with each other. Information sharing is also important when it comes to communication. And champions was also identified as being important because these champions not only help to kickstart integration, but they also help to sustain that momentum of integration. And lastly, role clarity was also another important part of integration. Again, it helps to prevent various organizational partners from engaging in duplication, services duplication, but also engaging in competition with each other. With regards to the external factors, I'll just very quickly talk about these factors. So governance authorities, whether healthcare or social care, or at different levels of government, they were viewed as exerting both a positive and negative influence. On the positive side, they created direction for integration, which was very supportive. But on the negative side, they tended to be very bureaucratic and often resulted in duplication of efforts. When it came to public policies also created a positive and negative influence. On the positive side, policies such as policies and government commitments around healthy aging, around integration, around immigration settlement, poverty reduction, all of these kinds of policies in the various cases that I saw really helped to support and foster partnership among the different players in all the different sectors that were involved. However, there was one common legislation that was identified as a key hindrance in all of the cases that I studied, and that was privacy. This really impacted the ability to engage in seamless care because a lot of organizations had to create workarounds in order to deal with the privacy issue. Working in the not-for-profit setting was identified as being a key enabling condition because a lot of the organizations could come together without the concern that there was a profit motive, because most of the organizations actually who were involved in the cases were not-for-profit organizations or government-based agencies. The strong sense of community was also tied to geography. And the strong sense of community is actually really important because the partners who had this strong sense of partnership and allyship with each other, generally tied with kind of these very rural and rural-urban areas, the sense of closeness really made that ability to move towards integration that much greater. In the case of the Toronto group, I think what was very interesting was that the strong sense of community was, yes, tied to this kind of North Toronto area, but it was also tied to the sense that a lot of the partners kind of had this strong sense of shared identity, that is, being providers who targeted a certain highly marginalized population, made them feel that they were kind of in this sense of a collection of partners. The last piece was patient characteristics, and it was very clear that age, social networks, complex healthcare conditions, and issues like poverty and housing all played a key factor in influencing integrated care, whether positively or negatively. Some key lessons learned include focusing on interorganizational factors. And that is, as important as issues around governance and agreements and measurement is, it was sometimes perhaps more important to really focus on building and nurturing those factors that focus on building trust, such as communications, shared vision and goals, interorganizational culture, team-based approaches. In addition, I think what this study showed was that it is possible for community-based organizations, whether community support agencies or healthcare agencies, that it is possible to engage in voluntary-based, grassroots-driven integrated care. It doesn't necessarily require government or health authorities to drive integrated care. Organizations can do that on their own and sustain it. All three of these cases actually have been in place for over 10 years and have been able to do so through that partnership. And lastly, it's important to nurture champions. They're very important when it comes to starting an initiative, and they're very important in sustaining it. And they're very important when it comes to turnover that often will happen when it comes to staffing issues. Just with the last couple of minutes, and I know that I've kind of went almost right to the point, and I apologize to this conference, but I wanted to touch on the role that the CSS sector can play in integrated care. I think there's very unique and important roles that the CSS sector can play. One is that the CSS sector can really help to provide that whole person-centered lens and really offer up the strong social determinants of health lens, because they are working in that space of, for instance, spaces around poverty, around housing, around social isolation, and their viewpoint and their perspective can really further deepen the integration work. In addition, the CSS sector, and as all of you are more than aware, you work deeply and with your clients, you have deep knowledge of their concerns and their background background. And you have, as a result of that, been able to build that level of trust. And this allows you to be able to reach out and engage those hard to reach and hard to service clients. For instance, low income clients, immigrant and racialized populations, for instance. And that's one critical value that you bring to the integrated health and social care tables. This is something we heard of often during the pandemic when we were trying to vaccinate hard to reach populations. Oftentimes, the CSS sector had to step forward and help to reach out to those communities. Related to this is this notion that the CSS sector can really play an important role in identifying emerging client issues and trends and patterns before it reaches a crisis. Because the CSS sector is so much ingrained and entrenched in their communities and have such deep ties with their clients, they have a sense of what is emerging, some of the emerging issues. And lastly, I think, which is an invaluable role that the CSS sector can play, is that the CSS sector can really offer up the ability to engage in integrated care within a culturally appropriate lens and with that cultural awareness and competence that's so important. So with that, I'd like to conclude my presentation and send apologies for having a little bit going way over my time. I'm always happy to be reached out in any of these emails and happy to take any questions.
Sumi, thank you so much for that presentation. Building on your analogy of there's no cookie cutter approach, you really did demonstrate though for us what the essential ingredients are for successful integration, and that in the end, however we formulate our own initiatives is really going to be up to us and up to the situation, but keeping in mind some of these factors is really important for how we're going to be successful in doing that. And certainly there is a lot of discussion right now within the OHTs, within Ontario Health Central itself, around integrated care pathways, integrated care continuums. And as you said, there really is no one definition. And so I think that's something to be mindful of, but also to recognize where we do bring our expertise and experience and the lens of the patients or the clients that can add that that extra value that often isn't recognized or understood in other integration models. So thank you for that. I don't see any questions in the question box. Michelle, I don't know if anybody was putting questions in the chat box for Sumi.
No, I don't see any questions there either, Christina.
Okay, thank you. Well, I guess we've got just a couple minutes left, but I would ask you, Sumi, from the perspective of Ontario health teams and the fact that there are opportunities between health teams as well as within health teams for integration. Where do you sort of suggest that the CSS agencies can start within their OHTs to take that leadership role that you outlined?
Yeah, I think some of the areas that in the last slide that I had pointed out, I think those are probably the key areas that the CSS role can have a really huge play at. I think the issue around targeting some of those priority populations, I know that Matt Anderson had mentioned them, but I think even within your various regions or communities is being able to identify those priority populations that sometimes get a bit sidelined because they don't have the voice and they don't have the agency because of the various, systemic issues that exist. I think that's one area where the CSS sector can really play a role and really try and advocate for making sure that they get that those client base and those care issues get a place on the agenda when it comes to the OAT movement. I know certainly, and certainly I would suggest when it comes to, and it comes back to, I guess, Dan Carbon's suggestion of engaging advocacy. I think there's an advocacy element of the community support sector within the various regions and communities that you exist is, that strength in numbers and bringing your shared collective concerns to the out tables to make sure that they don't get forgotten, that it's not just one agency that's seeing this. There's a trend and a pattern that needs to be addressed in a collective way within the region. I think is going to be critical for ensuring that the CSS sector issues and concerns get noted and that they have a collective voice at your various out tables. That's something that we're trying to do certainly in my area. And that's something that I think even with regards to, for instance, in the Alberta group, that, the primary care providers often were playing this advocacy role with the AHS to kind of say, hey, look, as young as that province is, and actually that is a very young province, there's like 12% of their population 65 and older. And meanwhile, in Camrose, 25% of their population is already 65 and older. And they often had to advocate strongly to say, don't forget, the older adult population is going to be a key emerging issue in the future for Albertans, and it should be a key concern for the Alberta Health Services. So I think that advocacy piece is critical and crucial for CSS sector.
Thank you. Well, we've come to the end of our time, so I want to thank Sumi so much for being with us here today and for providing us with such a wealth of information from your research. The session is being recorded and the slides will be available because I know people are probably trying to take screenshots and write furiously. But we do appreciate you being here, and thank you to all of the attendees who also took time to come and be better informed about integrated health and social care and some of those factors and dimensions that are so critical to successful ventures in that way.